Diagnosis of pain disorders. Pain in one or more anatomical site is predominant focus and warrants clinical attention. Kind of seems obvious, right? Pain causes significant distress or impairment in social, occupational, or other important area of functioning. Not so obvious, but it makes sense, right? If you're going to have a lot of pain somewhere, you're probably not going to be sitting in this lecture hall enjoying this lecture. Psychological factors judged to have an important role in onset, severity, exacerbation, or maintenance of pain, and that's the stuff we talked about. If you have another diagnosis, if you have a malinger, if you have secondary gain, if you have a brain tumor, another medical diagnosis, another psychiatric diagnosis, then you have to be aware that's going to interplay with the diagnosis of your pain disorder. Are you getting the point that treating pain disorders is quite complex? Now, I, as a psychiatrist, have decided a long time ago, because I do treat pain all the time, so I refuse to prescribe narcotics or actual pain meds, because I have all these other areas. And what does that do? That means the patients that see me know it's going to be a team approach. I'm not a cowboy. We talked about that, right? Because the first order of business when you take care of patients is make sure you're safe. Don't take risks you shouldn't be taking. So I think having a team approach is the way to go with this very delicate matter. So, we said non-malingering, not mood, anxiety, or psychotic disorder. Although you can have all these things and still have real pain. You know, even the malingerer in jail who thinks he's faking it because he tapped a nail through his hand actually has genuine pain. So we still have to deal with him. We still have to treat what he created for himself and why he would create that for himself. You're saying, well, because he's a sociopath. But sociopath and personality disorders, as you all shall see in Diagnostic Statistical Manual 5, which is coming out in 2013, claims that we need to treat those people. And we are now creating different treatments for them and different medications and different approaches to treat these personality disorders. You no longer can put them in the dustbin and ignore them. As you guys become doctors, you're going to be responsible in treating this group of people that for a long time, a lot of physicians didn't do well with. So be aware, this is going to be a big part of what you do in any field. From surgery to internal medicine to cardiology, you are going to be treating personality disorders under the new Diagnostic Statistical Manual 5, which is comprehensive in its approach to treatment and reality with these personality disorders. Did I scare you? Just a little, I was trying. Anyway, so this is from DSM-4TR. Anyway, we're going away from that Diagnostic Statistical Manual for transcribed because we're going to have DSM-5 come out before any of you get into medical school, probably. Except for maybe some people. Also, we specify acute, less than 6 months, and chronic, longer than 6 months. Pain associated with medical condition or psychological factors above. We've kind of gone through that. Psychopharmacology warnings. And this applies actually to all the medicines that doctors use, but I can only talk about my own field because I know my drugs really well. I don't know all the specialties drugs because, you know, as we hit another book called The Singularity is Near by Ray Kurzweil, we're doubling knowledge right now. 2011 and 2014 was a double. The last double was 2004 to 2011. By 2020, knowledge will double in less than a year. So you're not going to know anything but your own specialty. You're going to have to work hard to be comprehensive about that. So drugs or toxins, always look at benefit versus risk. Tricyclic antidepressants. My cardiologist friends do not have enough money to waste research on things that apply to psychiatry. But these medications that internists, GPs, and family practitioners use cavalierly, Elavil, imipramine, Pamelar, nortriptyline. I'll say some of the names so you're familiar. They all carry huge cardiac risk. And all of the cardiologists know this, but we haven't quite lowered the boom. Am I running out of time? Okay. They haven't quite lowered the boom on this. So the research projects are out there, but nobody says you can't prescribe them, but you have to be judicious. If you have patients with cardiac risk, these drugs become antiarrhythmogenic if you start having a myocardial infarction. So So that's a danger. Mixing, as with Anna Nicole Smith, we talk a lot about that now, because many of us in psychiatry do use a lot of mixtures of medications. We worry about them, but we try not to overdo it. Now, she got too many SSRIs, she got serotonergic poisoning that no one noticed, she was walking into walls, and probably she died of cardiac tamponade. So somebody should have been more aware. The bigger the celebrity is, the less awareness there is of the medical treatment. It's almost better to be unknown if you want good health care. So use of psychotropics in pain. Say you have a pure pain patient, just pain. Are there things in psychopharmacology that can help me with this patient? Yes, I can use Aricept, right? Aricept or Provigil for opioid-induced sedation. Donepezil, Aricept, we use it for Alzheimer's. It's an anticholinesterase inhibitor drug, ACHE blockade drug, so it increases acetylcholine by getting rid of the inhibitor. And one of the early researchers in that area is me. I wrote an article at UCLA with some other folks about this whole line of reasoning, and it became these new drugs, Aricept, Razodine, Escalon. I don't know if they really work. The studies we were doing, they told us we used too high a doses, but they didn't work well in our patients. We all know that we use these. The best use of that drug is if someone gets psychopharmacology fog. If you're taking a bunch of psychopharmacology drugs that you need and your brain cognition is going down, taking a little Aricept will clear you all the way up. That's the best use for that drug that I've seen. Provigil is a wakefulness drug. Supposed to have no amphetamine-like qualities. That's wrong. It has a little amphetamine quality in one particular spot in the brain. It's not all over the brain like dexedrine or something. But obviously that's why it helps for sedation. So we're giving one drug, then we're giving another drug to try to get rid of side effects. We do that a lot in medicine. Duloxetine, which is Cymbalta, for emotional and physical symptoms of pain. There's been a lot of stuff on the TV, a lot of advertisements for Cymbalta for pain. They're almost trying to let you think it's a pain medicine, but it's an antidepressant. And by the way, none of these antidepressants are antidepressants. The ones we're talking about here are actually mood elevators. True antidepressants are like lithium, some of the antipsychotics, some of the antiepileptics. Just so in case somebody wants to get specific on me, I've said that. The TCAs and SSRIs for rheumatic conditions are well documented. That's where the pain doctors use 25 milligrams of Elavil. Actually, Elavil to get rid of a depression takes about 400 or 500 milligrams. We used to do blood levels. And no one can tolerate more than 25 milligrams. It's such an awful drug. But it was, it was the beginning. It makes me think, so what is barbaric now? We're still being barbaric. If you look at yourself through the doctor's eyes 100 years from now, I'm still going to be doing things wrong. So I try to think of that all the time, and especially when I'm dealing with pain patients. SSRIs for back pain, fibromyalgia, and for osteoarthritis. That OA is osteoarthritis. More use of psychotropics for pain. Metrazapine, zonisamide. Metrazapine is a selective serotonergic reuptake inhibitor, in case it wasn't confusing enough. And zonisamide is one of those anti-epileptics that helps you lose weight, gets rid of some pain, and gets rid of anxiety, as long as you don't have a sulfur allergy. It's a sulfur drug. And it can cause kidney stones and problems with glaucoma. Metrazapine has the same warnings as all the other SSRIs. Gabapentin for post-op pain and anxiety relief. This is Neurontin. It's a fairly worthless drug that doesn't work very well, but patients think they're taking something, and that can be good. Some people don't need a lot. Lamotrigine for diabetic neuropathy and post-stroke pain. One of the worst pains you can get on earth is this diabetic neuropathy or post-herpalgic neuropathy. Have you seen people who've gotten this? They get like I got a cold sore once. What is that? I got the shingles once when I was a little older, and for like 3 days I couldn't sleep because the pain was that bad. But I was in Vegas, so I just gambled. So it was okay, it worked out. And I wasn't that, I knew it was going to go away. I don't know why I knew it was going to go away, because a lot of these people doesn't go away. They have to go on this mixture of medications that are anti-epileptics and pain meds, and then talk to someone. either a neurologist or psychiatrist to get through the supportive issues that they're dealing with, and then they have to deal with the family issues because their family's going, yeah, sure, you got problems. You know, because you don't believe people with these neuropathic pain syndromes, but I didn't sleep, so, but compared to the other pain I told you guys about, that was probably an 8. So 8 was tolerable. Just couldn't sleep. So, and also Cymbalta's been used for this diabetic neuropathy. Novel concepts for future drugs. I'm almost done. You guys okay? Okay. For future drugs, adenoreceptor, this is agonists, so this would be things like amphetamine-like agents and those kinds of things. The ones it's talking about really are like Theta, and if you've heard of these drugs, if you haven't, don't worry about it. Perstic, those kinds of things that are more pure SNRIs instead of SSRIs. Serotonin receptor ligands, which I think they've fallen into disfavor of some sort of serotonin receptor kind of got a hold. And an excitatory amino acid detector antagonist, I don't think that really went anywhere. Neuropeptide agonist, that didn't go anywhere. Voltage-gated ion channel blocks, this is where they get the little electricity. Cannabinoids, you know, they're very promising. There's another factor in the cannabinoids besides the THC that seems to be good for some pain syndromes and doesn't get you high at all. So they're working on separating that out. There's some drug companies working on that. And the nerve growth factor. The reality is that the major change isn't even on there. But I didn't know that 2 years ago. The major change is called deglycine drugs. And it has to do with NDMA, antagonism, and agonism, and glutamate metabolism. Turns out that they're like brightness and contrast, and they can reduce psychosis if you get them right. So if the pain's making you nuts, you take a deglycine drug, you're going to feel better, even better than the atypical antipsychotics. That's coming and should be here in 2 to 3 years. They already had Made in Jersey or something. It was a TV show that failed in 2 times. But one of the original episodes had a lady who got rid of her schizophrenia on this deglycine experimental drug. I was so impressed with them for talking about something that no one knows about. That's the first time I've seen that on a TV show. But naturally, the show sucked, so it went away. What can we do? So psychodynamic treatments, something I'm supposed to be good at. Cognitive behavioral therapy, supportive psychotherapy, family therapy, insight-oriented therapy, and grief therapy. We've talked about 4 of those. Grief therapy, why grief? Well, let's talk about it. Someone like me, I mean, I used to be an expert skier. I can't ski anymore. I've had my knee replaced. I've had radiation. I've had cancer. Can't ski anymore. There's grief involved in that. You know, and a lot of people are grieving what happens in the aging process. They lose things as you go along. You don't stay perfect in life. The only perfection in life is birth and death. So you have to deal with it. And there's a lot of grief involved in these things. And a lot of maturity process. I mean, you guys will, you know, never know what it's like to taste food for the first time again. Like the babies do. They get a big kick out of that. You'll never know that. There's a little grief for that probably somewhere, but you don't remember it.